So, hello everyone, it is a great pleasure for me to be here. Just forgive me if I take a couple of moments to thank all of you. First of all, I would like to sincerely thank the SASL and for your kind invitation and the warm hospitality. We are truly delighted to take part in this year's annual Congress and to be hosted here in Riyadh, that we consider a vibrant and inspiring city that perfectly reflects the spirit of collaboration and innovation in hepatology. As the world's leading scientific society in hepatology, ACLF is deeply committed to building a bridge between Europe and the Middle East. This is something that we really want to do. And not only because we are geographically close, but also share a strong common interest in advancing liver health, research, and clinical excellence. I hope that this event will mark just the first step in a strong and lasting partnership between ACLF and SASL, one that will continue to foster collaboration, education, innovation, and across our regions. I'd like to extend my heartfelt thanks in particular to Dr. Saleh, thank you very much for the hospitality, Dr. Faisal Abakhail, the president of the SASL, and the organizing committee as well, as the colleague in the hospital, Dr. Bandar, and all the liver transplant team that showed yesterday the amazing hospital that you have here, the King Faisal Hospital. So thank you very much for the invitation. Now we are starting to talk about the presentation. As you know, we decided to have a different topic in this ACLF-SASL session meeting, and it will be the first part on liver transplantation. Then all the other ACLF representatives will talk about hepatocellular carcinoma, MASLD, autoimmune hepatitis, and viral hepatitis, and I take also the timing to thank all my colleagues from the EASY Governing Board, Professor Svein Franke and Dr. Emma Calver, and the other two representatives, Dr. Sherry Buri and Professor Maria Buriti. Just the last thing, I would like also to thank our CEO, Ben, that is here representing ACLF as well. So, I'm talking about liver transplantation and acute and chronic liver failure. As we know, it's an acute decompensation of the liver that can take to the failure according to the Cliff score and with a very high mortality in 28 days. These are all one of the oldest diagnostic criteria that we've been using from the ACLF Cliff Consortium, and these are all the definition about the different stage of acute liver failure. Phase 1, 2, and 3. It depends from the number of organs that are involved in the disease. And the organs that can be involved are almost all the organs in our body, in particular, of course, the liver, the kidney, the brain, the coagulation, and respiratory and circulation. So this is something that it can be really, really a difficult management in the world of these patients. Recently, ACLF with the North American Society and the APASL made some new definition about the blood test and the scoring system that you can have. This has been just published in gastroenterology, and these are again all the organs system that are involved in the disease. And they, of course, added also the immune system and the GI failure, because these two organs are very important in the management, in the prognosis of a patient with acute and chronic liver failure. We have to consider the acute and chronic liver failure a dynamic syndrome. Why it is important being a dynamic syndrome? It is important because we need to reassess the patients and the grade of the critical. So those with severe persistent ACLF have the worst prognosis. If we take an example patient with ACLF 3 and they're starting with a probability of mortality that is about 64%, at the end of the follow-up, this patient in the 80% of the cases, unfortunately, they won't make it. Instead, if we consider those with the ACLF grade 1, this is much, the prognosis of these patients, of course, is much better. So what about how can we consider this patient? The EASL guidelines showed 6 clinical phenotypes: a patient with a stable disease, with stable decompensated disease, stable, unstable decompensated disease, those patients with the pre-ACLF, and then the different grade of ACLF. So if we look at the mortality of this patient, again, those with the worst starting point are those that will have a higher mortality rate in their natural history of disease. So what is the bundle of care? Of course, first of all, the precipitating event, the organ support, and of course, if we can offer them liver transplantation. So I will focus on precipitating event and the possibility of transplant these patients. First of all, what are the diseases that are the drivers of this kind of event? Of course, the diseases are different because, as you know, in the European side, the main disease that drives the ACLF are the alcohol, while in other parts of the world it can be more the reactivation, for example, of hepatitis B. So this depends from the area where the patient is living. And if we look about the precipitants, acute precipitants, of course, alcoholic hepatitis, again, it can be more frequent in the aposal area, and regarding the European area, the infection, the systemic infection, is the driver of the ACLF. Bundle of care management, liver transplantation. This is the key of the presentation. We know that if we have a good management of this patient, we can have a really good transplant benefit, in particular in those with ACLF1 and ACLF2, and for selected patients with ACLF3. So also those that are in the stage of more advanced liver disease. I've showed this paper that is just been published from China because, of course, again, we underline that if we consider the low-risk patients with the best donor, these are those patients that will have a better survival after the transplantation. So which are the cause of death in this case? Mostly infectious disease, but they can have also some cardiac heart complication, shock driven by infectious disease, sometimes respiratory, cerebrovascular. So these are all those that are reported in this Hermnight's paper in JEP a couple of years ago. What about the living donor? I just added this slide because I know that you are doing a lot of living donor in this area. So, of course, we always thought it's a difficult possibility to offer a living donor in this patient. But, of course, the survival in this patient will be much better than in those with cadaveric liver disease. And in particular, in those with grade 1 and grade 2, is not many difference between living donor and the cessus donor in grade 3 patients. So this is another possibility. But how can we select the patient for listing? General rules: no blank and white scenario. We have to do a longitudinal evaluation, so we have to analyze when there is destabilization and if the patient has an early response to treatment. And then we have to answer the following question: has this patient an acceptable odds for early postoperative survival? Has a favorable post-liver transplantation profile about adherence? This is something that is very important, in particular in those that have been, that will be evaluated in alcoholic liver disease. So the main problem is the transplantation window. So what we want, if we won't find the right window for this patient, if we miss this window, that will be the worst case. So we will miss patients. And we will not have a lot of windows in these patients. In particular, maybe when we start evaluating the patient, it will be at that stage non-transplantability, but then we have the first window. This is the timing. And in my opinion, having the possibility of having living donor liver transplantation, this is the key for these patients. Because then if you lose the window, maybe you can have also other windows. But the more time it passes, it will be more difficult to get this patient in the surgical theater for the transplantation. So this is something that we always have to remind, because otherwise we will have complication in patients that are admitted also in the intensive care. What about the tools to select? I've showed before the CLIF score, but now we have better tools, the CLIF score. For example, this TAM score is very useful. They analyze the arterial, they take in consideration the arterial lactate level, the presence or not of mechanical ventilation, the age of the recipient, the leukocyte count, and is just a very easy score, but we can characterize this patient very well, and as you can see, the survival rate in those that have a very low score is much better than the other ones. And the other score that's been used recently, we also have the Sundaram score, where we can analyze and find out about the futility of liver transplantation in case of severe ACLF. And we can also, thanks to this score, understand and having in mind how many days the patient will stay in the hospital afterward. That it's something very important as well. And what we are analyzing is the age, the BMI, the use of vasopressor, the presence of respiratory failure, and the presence of diabetes. So very quickly, I will go to finish my presentation with a very easy clinical case. 62 years male patient with alcohol-related disease, patient who was having TNF-alpha therapy for psoriasis, only one previous episode of acute decompensation, then was discharged and referred to outpatient clinic evaluation. He was admitted with a septic shock, ICU admission at neighboring hospital, so not in our main hospital, in noradrenaline, mechanical ventilation, no CRRT, cold liver transplantation, re-evaluation in 48 hours, little improvement, still on noradrenaline. The question is, should we take in consideration for liver transplantation this patient? So what are the toolkits? We said infection is the main cause of the disease of this patient. Screening for infection, MDR, and fungal infection. Never forget about fungal infection. We have to have a contrast-enhanced CT scan, of course, cardiac ultrasound, the blood group, and then in those with alcoholic liver disease, we have to talk about families and social workers and the psychological position of the patient when it is possible. Families, the main driver sometimes of this patient, so we need to have their support. Predicting post-liver transplant adherence. So we have to have a proper history to know about prior decompensation, if the substantial and more, and psychological evaluation, as we said, and the family as well. So if we look about our cases, yes, it was abstinent, of course, since previous prior admission to the hospital, only one episode of decompensation. It was the ETG was positive, of course. As a psychological evaluation, he had the driver license, he retired but had the job previously. And the family was very supportive. So just to summarize what we have been saying, patient with an algorithm to optimize post-liver transplant outcome. Of course, we have to have all the different evaluation, of course, addiction assessment, evaluation, overall health status. Then, thanks to these new scores, we can realize and we can define the boundaries of the transplantation window. And, of course, the main is the multidisciplinary meeting and evaluation of these patients. At some point, we can offer organ failure and the patient with the time window boundaries proceed to transplantation. Unfortunately, not all of them will go to transplantation. So this was in our hands a favorable profile. We controlled sepsis, we centralized the patients to our ward, and then we transplanted the patient. So the take-home message as a toolkit, transplant as best therapy. Think about it and investigate potential medical contraindication. Timing is very important. Discuss with the liver transplantation as soon as you can. So we sometimes get patients that have been in the ward in a small hospital for a while, maybe 10 days, 15 days. That's wrong. You have to centralize the patient as soon as you can. The earlier is the better. trend clinical reassess at least every 24-72 hours to estimate outcome. Improvement means stabilization and better post-liver transplant outcome. Estimate post-transplant survival with the different score that I've showed, and estimate also post-transplant adherence with the fast-track assessment. We can't wait to evaluate the patient as we normally do with the cirrhotic patients. This has to be a fast-track. You can't lose time for this patient, otherwise the patient won't be able to get transplanted. And finally, I want just to remind you that there is just a paper published in Clinical and Molecular Hepatology using machine learning, and the machine learning in this case was much better as a comparative predictive performance compared to all the scores, also the last one that I showed. So we can't avoid using AI in the future also for these patients. In conclusion, liver transplantation with severe ACLF is feasible and dramatically improve patients' prognosis. Major variables associated with outcome have been identified, and including them in the decision-making process might have precipitated in the observed patients' improvement of outcome over time. Many challenges ahead. Improving models, we have always to find the right model. Going further in the exploration of organ failures, and having a clear the futility thresholds, improving equity regarding access to liver transplantation, standardized pre-transplant workup, and improving peri-liver transplantation manner. So I would like to thank again for inviting us, you, and I also would like to remind you that we will have the annual meeting in Barcelona this year at the end of May, and we also have the Liver Cancer Summit in 2026 in Edinburgh at the end of January, and the Steatotic Liver Disease Summit in 2026 in Budapest at the end of February. Thank you again for your attention.